My name's Robert Fisher, Bob Fisher. I'm an MD, PhD. I'm director of the Stanford Epilepsy Center and the Maslow Saul Professor of Neurology at Stanford. I've been past president of the American Epilepsy Society and editor-in-chief of Epilepsia and of the main website for epilepsy, which is epilepsy.com. My research area of interest is devices for epilepsy, and I've led a few national pivotal trials for epilepsy devices, including, for example, the deep brain stimulator trial for Medtronic, which has led to approval in 31 countries now, and I hope this year in the US, and also the latest generation of the vagus nerve stimulator, which can sense the heart rate increase of a seizure and then deliver stimuli. I have no financial connection with EGI except I am using their equipment to do some research studies, and we also use it for clinical studies. So I do have hands-on experience with the dense array EEG. The first question you gave me is, what is my opinion on dense array, kind of in simple terms. I guess I should explain a little bit about what it is. A dense array involves two components. One is an electrode cap that has a much larger than usual number of electrodes, 256, compared to the more typical 19 to 30-something electrodes. It's done in a way that it doesn't require individual electrode gel to be placed on each one, or that would be a very time-consuming task. You can just dip it in saline, squeegee it, and put it on the head and start getting a good recording. The second component is the software that goes with those numbers of electrodes. And that many of electrodes, particularly distributed all around the brain, enables you to do what's called an inverse mapping of where the electrical source comes from in the brain. So, excuse me, consider, for example, someone who has seizures. We might be interested in cutting out the part of the brain that's critically involved in starting the seizure, but we don't know where it is. Sometimes the MRI may show a lesion that guides us. Over half of the time it will not. So we'll run EEGs, but we run them with electrodes pasted to the scalp. Typically, that gives us an area of which superficial region is closest to the seizure focus, but it doesn't tell us where it is in three-dimensional space. Should we be cutting out the surface of the temporal lobe, or should we be going for the structures deeper in that often give rise to seizures? So with the EGI electrode array, it's kind of a turnkey solution that will show, even on the patient's own MRI, where the calculated dipole is that best fits distribution of electrical voltages seen on the surface recordings. So we get that three-dimensional aspect, which, if we use a patient's own MRI, can be so precise that it may show us a source even on the side bank of one of the sulci, one of the inner folds of the brain, which would never be visible with standard kinds of EEG. Now, what does that accuracy let us do? In the current moment, would let us cut out the most suitable part of the brain. The patient is a surgical candidate, but I think in the future it's going to allow much more than that, because it will allow targeting of non-invasive therapy. I'd just like to make one other point as a practicing clinician and someone who's been reading EEGs for 35 years and has written EEG research papers and textbooks. When you start doing high-density EEG, it becomes a little bit unnerving, because you end up thinking that to some extent you've been reading EEGs wrong for the past 30 years, and that findings that you thought were localized to one region may in fact be localized to other regions, and things that you considered static processes, such as a spike in, let's say, the inner left temporal lobe, in fact, are moving electrical dipoles through the brain that may start in the inferior frontal lobe, spread to the left temporal lobe, and then spread to the right temporal lobe, and represent a much more complicated network process, none of which was visible by traditional scalp EEG. So it can be not only a diagnostic tool, but a bit of a paradigm change in how we look at certain disease processes in the brain.
So in terms of epilepsy, there's an analogy that I like to use all the time, which is you think about the brain as if it were an orchestra. You have different musicians playing different instruments. You have different parts of the brain that do different things, and seizures are usually caused by one musician who, instead of playing the song, plays an abnormal pattern, abnormal rhythm, and that can stay right there, or that can disrupt the next guy over, next guy over, next guy over, right? So EEG is a very good, any form of EEG is a very good listener, quote unquote, right? What EEG enables us is to see with very good temporal resolution if there is a disruption on the music. If there is that abnormal sound, quote unquote, that comes from somewhere. Obviously, EEG is not looking at sounds, right? It's electrical signals, etc. So that's it. And one of the main limitations of EEG has always been the fact that you can kind of tell that there's an abnormality somewhere in the orchestra, but you cannot pinpoint where. And at times, the bad player in the orchestra can be one guy, or it can be multiple guys in different places, etc. And EEG has always been limited in terms of providing us an answer as to where things start. High-density EEG has the advantage of providing information, or potentially providing information that is more localized to where the problem is. So it overcomes, or has the potential to overcome, the spatial resolution constraints that conventional EEG has. So for this reason, it has a lot of promise in the evaluation of epilepsy, because it could potentially tell where the abnormality is, where it started from, and whether it started from the same place in every single seizure. High-density EEG also has the advantage of being a non-invasive test, so you don't have to have intracranial electrodes and things like that. So somebody could have a high-density EEG today, they can have another high-density EEG the next day, etc. The second component is the fact that if you can accurately define where seizures come from in one individual, based on that person's anatomy, that may have a huge impact in terms of treatment. So by localizing things with specific anatomical, specifically to the person's brain, you can see the specific anatomical landmarks that that person may have, and that can greatly help guide surgery, potentially by just removing the area where seizures come from, avoiding areas that are eloquent, that do things like language, motor, etc. So two things, right? One is the accurate calculation where the voltage sources come from. The other thing is, now that you know in that person's own anatomy, you can tailor treatment to that person.
The interest in EEG is not going away. EEG is an old technique. It's been around since the 1920s. And despite all the advances in neuroimaging, EEG is still there. And the reason is that EEG gives us a neurophysiologic assessment, a functional evaluation of the patient. MRI, for example, is limited to structural findings, whereas EEG is functional. And so if you can combine those two, you'll have the best of both worlds. So the interest in EEG overall is not going away. It's expanding, in fact. In fact, with one of the major lectures at our last American Epilepsy Society meeting was given by Dr. Jean Gottman of Montreal, who expounded on the future of EEG. And one of the tools that he suggested would be important in the future is combining EEG recordings, especially high-density EEG recordings, with neuroimaging, including MRI, including fMRI, and other techniques. So I think that many people are coming to recognize that there's more to be had here than what we've been exploiting so far. What we're trying to do is not only make use of high density EEG for diagnostic purposes, but for treatment as well. And we're engaged in a project, Don and myself and maybe 1 or 2 other centers involved with selecting patients with refractory seizures, localizing epileptiform activity using high density EEG, fusing those findings with the patient's own MRI, and then delivering transcranial electrical currents in order, with the end point is, can we suppress epileptiform activity using transcranial electrical stimulation? There is abundant literature out there that says that this is a potentially useful technique. And so we're right now in the throes of that project. But so I think the future may be that we can combine not only diagnosis but treatment non-invasively. Other potential uses would be to localize motor cortex using non-invasive stimulation, to localize perhaps other areas as well, such as language area. So I think the future is going to be bright for applications of this technique to other areas. Now, I'm just talking about epilepsy, but it's very possible that this can be useful for other disorders as well. Although I'm not really going to follow that myself, but I can foresee where other people may want to get involved in applying these techniques for the diagnosis and treatment of other conditions.
Dr. Holmes, you brought up something intriguing there as far as using stimulation to localize language and motor cortex. Why would that be important?
Well, okay, if for example, let's get back to a practical point. If you have somebody with refractory seizures, for example, and you think the seizures come from, say, the left hemisphere, left temporal lobe, lateral temporal lobe. For 95% of people, the left temporal lobe is dominant for language. And you need to know for sure where that language area is for that one person. Many investigators have shown that the language area differs from person to person in terms of location and the extent of cortex that is involved with language. So how do we do it now? Well, how we do it now is we put a grid of electrodes over the cortex and we stimulate at the bedside through that invasive grid of electrodes the brain surface to localize language area. And what the endpoint is, you have the patient, for example, name objects. When you stimulate and they stop naming, you know you're at it. You know the area of interest. The other way of localizing language is to do it invasively. And at the time of an operation, the surgeon will stimulate directly on the brain surface while the patient is awake in the operating room. And then the surgeon can localize the language area that way. So it's done either at the bedside through the series of grid electrodes or invasively at the time of the operation. So, I mean, that's fine, we can do that, but can we do that non-invasively? And I happen to think we probably can. We have not done that yet, but I think it's very possible. I see no reason why it can't be done non-invasively.
Yeah, it seems like it'd be nice to go into that operating room with a plan and location already intact as opposed to having to figure it out along the way.
Exactly. Why not do as much as you can non-invasively? Localize language area, localize motor cortex, localize the seizure onset zone. I think those are all areas or all things that can be done non-invasively. That's how I see the future. I think the future is pretty clear in terms of what we will be able to use with this new technology.
Yeah, a big important part for Philips is we believe getting quickly to a definitive diagnosis for the patient and then putting these guidance tools together. It does a lot, not just for individual patient outcomes and clinical evidence, but we think it can do a lot towards efficiency and predictability of the procedure as well. And that's something we've heard is important, is that, if you know that procedure is only going to take 2 hours, you're a lot more comfortable scheduling 3 patients that day and not risking having someone stay overnight because the first procedure went long. Is that a challenge that you see at your center?
Yes, of course. I mean, I think that if you can, you know, from beginning to end, the evaluation of somebody right now with refractory epilepsy is quite extensive and very costly. I mean, I think that in the future, once these technologies become fully developed, the cost of doing this will be dramatically reduced. Reduced number of hospital visits, reduced operating room time. All these factors will be reduced in terms of the need for them, I believe.
How dense array, first of all, we can localize the epileptogenic focus. We need it primarily to as an imaging tool for patients who will undergo surgery. And this is an imaging tool which is showed its excellent yield. So if you combine it with MRI, then and both are together, we show that this is a more than 90% chance to be seizure-free operatively. You can't pretty much cannot have it better than that.
In aspects of how I've evolved in acquiring this technology and then implementing it into clinical use, it has to also do somewhat parallel with what I've done on a clinical realm. But my initial foray into high density or dense array EEG was more a combination of what's better for the patient, because the modality utilizes, as you know, a sensor net to sort of apply all these electrodes, 128 or 256 electrodes in a very, very rapid fashion, but doesn't require any electrical bridge by abrading the scalp or using these sort of toxic glues called collodion and some of the other ones that are utilized. And so it's extremely patient-friendly. And in the population that I deal with mostly, which is behaviorally challenged and neurodevelopmentally challenged individuals, we need something that is very, very non-invasive and easy to use. It's very, very rare that we don't get an EEG in very challenged individuals on the first try and occasionally on the second try, but that's even not very common. So now we have a study that's reliable and acquirable in challenging populations. So from a diagnostic standpoint, that improves your compliance rates. Also, a lot of these individuals require multiple studies or serial studies. They might require a repeat study at some time to see if your intervention, your therapeutic intervention, has changed the quality of the EEG or the abnormalities of the EEG. And if you take someone maybe who's intellectually disabled or autistic or behaviorally challenged or just plain anxious, they remember their experiences, if you will, and if they've had a bad experience with a conventional EEG, they're not going to be so compliant the next time around. So we've increased compliance rates on repeat studies. So acquisition is a big issue with high density EEG. The other big issue is obviously the diagnostic quality of the study. The model, as you know, is this concept of applying more electrodes to the head, acquiring more data points, and then by using these different data points, seeing how they model in 3 dimensions or sort of intersect, if you will. And it allows you to be a lot more confident on where your electrical activity is coming from, whether it be normal or abnormal. And one of the arts of EEG interpretation is understanding, if you will, what is a sort of normal variant, what is artifact and needs to be discarded, and what is a truly abnormal finding. On conventional EEG, there's a few issues. The conventional EEG is usually about 18 to 20 electrodes, and as you know, in dense array, it could be up to 256, but we use 128 in our clinical practice, our outpatient practice. And number one, what happens in EEG on a technical basis, especially when they're glued onto the head, is sometimes these electrodes go bad. They stop losing their ability to detect the electrical activity from the brain. And so if you lose, let's say, 2 electrodes go bad on a conventional EEG, well, you've just lost 10% of your data points. If you lose 2 electrodes on a high density EEG, you've lost, less than 1% of your data points. So that's a big difference. So the issue really is that you could have a much more larger margin of error, if you will, in terms of the acquisition and then the quality of the data. But also by increasing to almost 6 times the number of electrodes, you're increasing your data points by over 6 times. So you now have this ability, again, like I mentioned before, to electrically image the brain activity in 3 dimensions. Even though you're applying surface electrodes to the outside of the head and you're not actually invading into below the skull, you could still create and recreate a 3-dimensional image and try to determine where electrical activity is occurring from. I mean, the neurophysiology is a major piece. I mean, neurophysiological measurement is again a window into brain activity that's non-invasive and can be done in an office setting. We look at other things. We look at neuropsychological abilities, which is also sort of a measurement of function of what you could actually output and what kind of actions you could actually do from the brain. We look at genetics, which is very important. We look at metabolics. I mean, we put all these pieces together, but the neurophysiology piece is an important signature of brain function and can really then help us in many respects. In many cases, we've had to sort of help people end their diagnostic journey by detecting certain abnormalities on EEG that might typically not be seen. So we've also published and we've reported also at some recent meetings our experience with what we call unexpected subclinical spikes. So spikes are little brain discharges that are often associated with seizures and epilepsy, but can also occur in people who don't have any observable events that would classically be labeled as seizures. And we've been able to demonstrate in a large number of these patients, 15 to 20% of the time in patients who have autism or ADHD and learning problems, and no known complaints of a clinical event that would suggest a seizure, we've seen these abnormal spikes, and sometimes we've seen them quite abundantly, and sometimes, in some cases, we've been able to relate them to a genetic change as well. But the bottom line is, in these cases, we've also been able to demonstrate that many of these cases have neuropsychological dysfunction, and when we treat for spike suppression, in other words, when we give medications to suppress the spikes, their neuropsychological function improves, their behavior improves, and their overall life improves. So again, this provides a biological treatment target through the EEG as the neurophysiological signature, and then sometimes some other ancillary testing as well. And it ends, if you will, what we call the diagnostic journey. So a lot of individuals with unexplained problems, which is the majority of the patients that we see in the neurological and neurodevelopmental realm, which haven't really been defined biologically, they go on what we call a diagnostic journey. They go from place to place, practitioner to practitioner, looking for answers. And they may get suppression of symptoms with medications that often have side effects and other toxicities, but until you really understand what causes somebody's problems, what causes somebody's symptoms, you really can't treat them efficiently. It's the analogy I often give is an area, let's say cancer, where cancer, you don't treat cancer. You try to biologically define it in its different subtypes. And once you understand the biological subtype, then you can have a more efficient treatment. So I think in the area of neurodevelopmental disabilities, in the area of intellectual disabilities, in the area of neurobehavioral neuropsychiatric disorders, which is a quite large number of the population, that model, that biological model, has been either neglected or avoided or just misunderstood. And that's what we're trying to get back to that. And I think an important piece, I mean, if you're talking about something that is a brain disorder, you need that neurophysiological piece to really understand how the brain is functioning.